Disease Thinking, Dissolving Questions About Disease, Part 1. Sandy is a morbidly obese woman looking for advice. Her husband has no sympathy for her, and tells her she obviously needs to stop eating like a pig, and would it kill her to go to the gym once in a while? Her doctor tells her that obesity is primarily genetic, and recommends the diet pill Orlistat and a consultation with a surgeon about gastric bypass. Her sister tells her that obesity is a perfectly valid lifestyle choice, and that fatism, equivalent to racism, is society's way of keeping her down. When she tells each of her friends about the opinions of the others, things really start to heat up. Her husband accuses her doctor and sister of absolving her of personal responsibility with feel-good platitudes that in the end will only prevent her from getting the willpower she needs to start a real diet. Her doctor accuses her husband of ignorance of the real causes of obesity and of the most effective treatments, and accuses her sister of legitimizing a dangerous health risk that could end with Sandy in hospital or even dead. Her sister accuses her husband of being a jerk, and her doctor of trying to medicalize her behavior in order to turn it into a condition that will keep her on pills for life and make lots of money for Big Pharma. Sandy is fictional, but similar conversations happen every day, not only about obesity but about a host of other marginal conditions that some consider character flaws, others diseases, and still others normal variation in the human condition. Attention deficit disorder, internet addiction, social anxiety disorder, as one skeptic said, didn't we used to call this shyness? Alcoholism, chronic fatigue, oppositional defiant disorder, didn't we used to call this being a teenager? Compulsive gambling, homosexuality, Asperger's syndrome, antisocial personality, even depression have all been placed in two or more of these categories by different people. Sandy's sister may have a point, but this post will concentrate on the debate between her husband and her doctor, with the understanding that the same techniques will apply to evaluating her sister's opinion. The disagreement between Sandy's husband and doctor centers around the idea of disease. If obesity, depression, alcoholism, and the like are diseases, most people default to the doctor's point of view. If they are not diseases, they tend to agree with the husband. The debate over such marginal conditions is in many ways a debate over whether or not they are real diseases. The usual surface-level arguments trotted out in favor of or against the proposition are generally inconclusive, but this post will apply a host of techniques previously discussed on Less Wrong to illuminate the issue. What is disease? In Disguised Queries, Eliezer demonstrates how a word refers to a cluster of objects related upon multiple axes. For example, in a company that sorts red smooth translucent cubes full of vanadium from blue furry opaque eggs full of palladium, you might invent the word rube to designate the red cubes, and another bleg to designate the blue eggs. Both words are useful because they carve reality at the joints. They refer to two completely separate classes of things which it's practically useful to keep in separate categories. Calling something a bleg is a quick and easy way to describe its color, shape, opacity, texture, and chemical composition. It may be that the odd bleg might be purple rather than blue, but in general the characteristics of a bleg remain sufficiently correlated that bleg is a useful word. If they weren't so correlated, if blue objects were equally likely to be palladium-containing cubes as vanadium-containing eggs, then the word bleg would be a waste of breath. The characteristics of the object would remain just as mysterious to your partner after you said bleg as they were before. Disease, like bleg, suggests that certain characteristics always come together. A rough sketch of some of the characteristics we expect in a disease might include 1. Something caused by the sorts of thing you study in biology, proteins, bacteria, ions, viruses, genes. 2. Something involuntary and completely immune to the operations of free will. 3. Something rare, the vast majority of people don't have it. 4. Something unpleasant, when you have it, you want to get rid of it. 5. Something discrete, a graph would show two widely separate populations, one with the disease and one without, and not a normal distribution. 6. Something commonly treated with science-y interventions like chemicals and radiation. Cancer satisfies every one of these criteria, and so we have no qualms whatsoever about classifying it as a disease. It's a type specimen, the sparrow as opposed to the ostrich. The same is true of heart attack, the flu, diabetes, and many more. Some conditions satisfy a few of the criteria, but not others. Dwarfism seems to fail. 5. And it might get its status as a disease only after studies show that the supposed dwarf falls way out of normal human height variation. Despite the best efforts of transhumanists, it's hard to convince people that aging is a disease, partly because it fails. 3. Calling homosexuality a disease is a poor choice for many reasons, but one of them is certainly, 4, it's not necessarily unpleasant. The marginal conditions mentioned above are also in this category. Obesity arguably sort of satisfies criteria, 1, 4, and 6, but it would be pretty hard to make a case for 2, 3, and 5. So, is obesity really a disease? Well, is Pluto really a planet? Once we state that obesity satisfies some of the criteria but not others, it is meaningless to talk about an additional fact of whether it really deserves to be a disease or not. If it weren't for those pesky hidden inferences. Hidden inferences from disease concept. The state of the disease node, meaningless in itself, is used to predict several other nodes with non-empirical content. In English, we make value decisions based on whether we call something a disease or not. If something is a real disease, the patient deserves our sympathy and support. For example, cancer sufferers must universally be described as brave. If it is not a real disease, people are more likely to get our condemnation. For example, Sandy's husband who calls her a pig for her inability to control her eating habits. The difference between shyness and social anxiety disorder is that people with the first get called weird and told to man up, and people with the second get special privileges and the sympathy of those around them. And if something is a real disease, it is socially acceptable, maybe even mandated, to seek medical treatment for it. If it's not a disease, medical treatment gets derided as a quick fix or an abdication of personal responsibility. I have talked to several doctors who are uncomfortable suggesting gastric bypass surgery, even in people for whom it is medically indicated, because they believe it is morally wrong to turn to medicine to solve a character issue. While a condition's status as a real disease ought to be meaningless as a hanging node after the status of all other nodes have been determined, it has acquired political and philosophical implications because of its role in determining whether patients receive sympathy and whether they are permitted to seek medical treatment. If we can determine whether a person should get sympathy, and whether they should be allowed to seek medical treatment, independently of the central node disease or of the criteria that feed into it, we will have successfully unasked the question, are these marginal conditions real diseases, and cleared up the confusion.